28-year-old female.
Is there a case number?
Miss Kalyani, hailing from Ongole, Andhra Pradesh, working as a village revenue officer by occupation, educated till M.Tech, and she has a post-renal status, transplant status. Presently came for review, informant being herself and her father, which is reliable. I would like to date back my history to 2016, when the patient was of 21 years age. At that time, she noticed swelling in bilateral foot, but she ignored, considering it as normal because she was traveling for a prolonged periods at that time. She was in her final year BTech and used to do up and down from home to her college. This edema also she noticed, it used to be more towards the evening and reversed the next day morning. For 5 to 6 months, she didn't consult any doctor for this edema and it was not associated with any other symptoms. After that, she noticed swelling of face, around eyes and decreased urine output also, with increasing fetal edema up to knee, which gradually progressed and it became difficult for her to do her daily activities because of heaviness in the legs. So she consulted a local physician where she was evaluated with blood and urine investigations and told that she was leaking protein in the urine and advised to consult a specialist doctor. She consulted a nephrologist and there she was subject to further blood and urine investigations and was told to have leaking protein, minimal blood and needs kidney biopsy for further management, and told her that renal functions were normal at that time. She underwent a kidney biopsy in February 2017, which she remembers is uneventful. At that time, she was told kidney biopsy and blood investigations are suggesting same diagnosis, that is SLE, and she needs treatment for a minimum of 2 to 3 years. So she was started on few IV injections and 2 to 3 oral medications, which used to cost around 7,000 per month for her. And direct questioning also, she is not able to get number of injections and frequency of injections she received. After starting the medication, she improved symptomatically, but she clearly remembers her protein leaking never disappeared. She was told to have there is urine protein always, and it used to be 2 to 3 plus positive. As she is completely asymptomatic and she used medication for 1 year, and in 2019 because of COVID pandemic she left the medication. Again after 6 months she noticed pedal edema and facial puffiness. Without consulting treating doctor, she herself started previous medications and used it for 6 months. This time her symptoms persisted despite of using medication, and because of family pressure she started using Ayurvedic medicine for a duration of 6 months, details of which she doesn't remember. Used to take 2 white color balls twice daily. In spite of this, her symptoms worsened. Again, it became difficult for her to do her daily activities. She returned to her treating nephrologist. And this time, she noticed decreased urine out associated with nausea, vomiting, and loss of appetite also. There, she was investigated and told to have decreased kidney function and advised hemodialysis. Same time, she was told to have a high BP recordings and started on medications. Prior to this episode, there was no history of any rash, headache, bleeding manifestations, arthralgia, passing red color urine, reduction in urine output. No history of dryness of mouth, excessive irritability of eyes, oral or genital ulcerations or visual disturbances. No history of convulsions, psychotic behavior or behavior of cognitive decline noted. No history suggests of high risk behavior. As she was advised dialysis, she came to NIMS for further management, that is in June 2020. Here, because of volume overload and associated uremic features, she was initiated on hemodialysis through right non-tunneled IJV catheter. After 5 sessions of dialysis, she became clinically stable and her urine output also improved. So she was investigated further with blood and urine investigations and advised repeat biopsy in August 2020. After biopsy, she was informed that her kidney is almost damaged and she needs to continue hemodialysis 2 times a week. She was explained about renal transplantation and her mother was willing for donation. But in view of her persistent blood and protein leak in urine and abnormal blood report, she was told to continue the medication which she used in a 1 year period and advised regular follow-up for transplant workup. In this admission only, left BCF was created and discharged with advice to continue MSG 2/7 at her local place. She continued MSG 2 times per week through left BC AV fistula. Her intradialytic weight gain was around 1 to 1.5 kg. Urine output remained around 800 to 500 ml. There was no history of excessive alarms during HD session, no history of intradialytic hypotension or hypertension, fever, chills, rigors, muscle cramps during HD sessions. Till February 2021, she didn't have any complaints and was on regular follow-up in NIMS for transplant workup with her mother as donor. During this period, she developed new onset asthenia, which is progressive and excisional dyspnea, for which she evaluated and found to have low blood percentage and started on weekly iron injections and advised to stop prior medications. She was continued on oral iron supplementation, calcium and BP medications. She received hepatitis B vaccination and COVID-19 vaccination. There was no history of blood transfusions, no emergency admissions during this HD period. In August 2020, this is after 1 year of starting MHD, she noticed the absence of the vibration sound over her fistula. And on direct questioning, she told from 3 to 4 previous sessions of HD, there was a decreased blood flow through the fistula, and her dialysis sessions were terminated early, but she did not come up for evaluation. In September 2020, she came for regular checkup and advised admission for further transplant workup and transplant surgery. During this period, her HD sessions were continued through right IJV non-tunnel catheter. In October 2020, she underwent ABO compatible live-related renal transplant, mother as a donor. Coming to donor details, she is a 55-year-old female, patient's mother, blood group is A positive without any comorbid conditions. She had 2 successful pregnancies and no history of abortions. There were no issues during workup also. She remembers she was given 1 costly injection, 2 doses on the day of surgery and on day 4 post-surgery. Post-op period was uneventful with immediate graft function and urine output. She was discharged on POD day 7 with urine output of 5.5 to 6 liters per day and had serum creatinine at the time of discharge of 1.003 milligram per deciliter. And started on tablets, MMF, tacrolimus and Vislon doses which she don't remember. And few other medications, advised follow-up thereafter. Till November 2020, she was completely asymptomatic and was well compliant to medications. During November 2020, that is 13 months post-transplant, she started noticing pedal edema, facial puffiness. This was not associated with any fever, rash, arthralgias, loose stools, nausea, vomiting, abdominal pain, decreased urine output, red color urine or loss of consciousness, tremors. For our above symptoms, she got admitted and an evaluation told to have again she developed protein leaking in the urine and there is no associated renal dysfunction, which she remembers to be about 3.2 grams per day, so advised renal biopsy. In December 2022, she underwent renal biopsy from transplanted kidney, which was uneventful. After the biopsy report, she was given 1 injection for 3 days, which she recollects being taken during the time of transplant surgery also. She was started on another oral medication and increased the dose of Vislon to 20 mg and discharged with further follow-up. For 2 months, her pedal edema, facial puffiness decreased but not completely. And there were troublesome for her to do her routine work. In February 2023, she developed fever, mild to moderate grade, associated with cough, expectoration of 3 days duration. During this episode, again she got admitted and evaluated and received IV medications, recovered symptomatically. At this time also, her protein leakage in urine was of same level and advised further workup. Because of financial constraints and lack of leave, she wanted to come later. Following this episode, her pedal edema, facial puffiness increased progressively over a period of 3 months. This time it was associated with decreased urine output, abdominal distension, nausea, vomiting and asthenia. In June 2023, she was admitted, evaluated and told to have renal dysfunction with creatinine of 2.5 and advised repeat biopsy. She was managed symptomatically and urine of low blood levels transfused with 4 points PRBCs and 5 points of platelet concentrates. Repeat biopsy done and she was told that transplant kidney is also got affected by the same disease which initially she had and advised special form of dialysis. In July 2023, she underwent 5 sessions of special form of dialysis through right IJV non-tunnel catheter alternate day and 5 doses of costly injection after each session of plasmapheresis. Following plasma exchange, she developed erythematous patches all over body but no clinically active bleeding manifestations at other sites. She was discharged and advised follow-up after 2 weeks for further management. At the time of discharge also, her symptoms were there, pedal edema, facial puffiness and urine output was around 1 to 1.5 liters. Now she came for review. Coming to past history, there was no history of diabetes, asthma, TB, seizures, CAD or COPD or any surgeries in the past. Family history, there is no history of similar complaints in the other family members. Coming to personal history, she is born out of a non-consanguineous marriage, second in birth order, full-term pregnancy, normal vaginal delivery, no INICU admissions and no development delay, and vaccinated appropriately. She is not married and she has one elder brother who is in good health now. Takes Imcivree, no addictions, bladder from past 2 months she complains of decreased urination, bowel is regular, sleep is good and appetite decreased. Coming to menstrual history, she attained menarche at 14 years of age. Till 26 years of age, she has regular menstrual cycles, no heavy, and it is a 30-day cycle, bleed 3/5. After that, she has irregular cycles in the form of amenorrhea for 2 to 3 months, and in between used to have menorrhagia. For the same complaints, I consulted a gynecologist and was started on progesterone tablets. After transplantation, again her menstrual cycles became regular within 2 months. Now she is having monthly regular cycles. Drug history, she used MMF for 2.5 years initially, Ayurvedic medicine for 6 months. After that, all the medications advised by nephrologist till now.
No, one suggestion for all the presenters is that in the exam actually the time is not infinite time. No? You are allowed to present even a long case history in 10 minutes. So that examiners would love to have more time for have a detailed discussion. So even though you have to take a very elaborate history, but you should know how to crop it up. There are a lot of information which are not really having any impact on the natural history of the disease or whatever. So all those things you should just have to leave it out. And then practice in such a way that the whole information is given in a kind of a very short form. So for instance, the story started in 2000. And again, one more thing, you are not supposed to read out from the paper. You should be looking into the eyes of examiners. That's very important. In between, you can just see the paper. Please practice that way. It is easy. It's not a big thing. You just write down everything, but you should be telling us. It's a kind of a storytelling. That's important. Anyhow, I appreciate you. You have very sincerely taken the history, but you just modify in such a way that for instance, in this situation, everything started in 2016 with the development of edema, and she was found on evaluation found to have proteinuria. She was told to have kidney disease. She was advised medicines. She continued, but there was no respite. So subsequently, she resorted to Ayurvedic medicine. That's all finished. And similarly, in the dialysis history, even if the dialysis vintage is for 10 years or 20 years, only 4 or 5 sentences. The important things are, of course, the timeline when it was initiated is important. Then the number of centers, number of access, major hospitalization, history of transfusion, history of vaccination. These are the informations we would love to have. If there are failures of the fistula happening and that have an impact, you believe that may tell upon some basic disease, you can be little more elaborate. Otherwise, some people will have very long history. Then the history will never end. So what will happen now at the end of it, it may be very difficult to keep a track of the sequence of events, and also the examiners may slightly get perturbed that the time given for them is minimized for discussion. So by practice it comes. You just crop up all those things and so on. So can you just, so you would like to finish the examination findings also? Yeah. Examination patterns.
Examination, so would I like positive findings?
Yeah.
Positive findings is like height is 154 centimeters, weight is 52 kg, BMI is 21, and BP is 120/90 sitting and 130/90 standing, no postural hypotension. And she is like a pedal edema is present, pallor is present, erythematous patches of different ages present, and she is in volume overload, and features suggest of steroid toxicity are present on clinical examination.
Graft examination you have done?
So graft examination, it is forms and non-tender cell.
What are the components of the graft examination? Because this is a whole story of the
inspection, palpation, percussion. So inspection, there is a well-healed scar over the right iliac fossa. There is no oozing or gaping, and palpation and graft is formed to palpate, and there is no tenderness over this thing.
Sometimes you can even approximate the size of the graft also. In a upper pole you can fill out if the patient is thin, if it is not too bulky and not too much of the fat.
She has ascites.
If it is there, then you can definitely tell us. If ascites were there, this was a positive findings. You should have told us there was ascites. Ascites, how you have detected ascites?
The fluid, like mild ascites only, sir, but the fluid trill was.
For that, what do you do? For mild ascites, what you demonstrate? How you demonstrate mild ascites on clinical examination? This is clinical examination. We should have trained us. Have you heard the name of shifting dullness? So you should have told us that this is a positive findings, na? So sometimes if there is no ascites, you can have this, you can approximate the upper pole, lower pole size of the graft and tenderness for the graft, and then on expectation is important.
So any brewery?
Yes.
The graft, so there are some, because there is not too much of the things to examine in nephrology practice, and there are few important things there we should concentrate on.
Right. So, can you come up with a diagnosis?
So my final diagnosis is CKD-T, live-related renal allograft recipient, ABO compatible, mother as donor, with the besiliximab induction and maintenance triple immunosuppression with immediate graft function. Native kidney disease is CKD, CGN, SLE, biopsy-proven SLE, status post MMF therapy, and developed DSRD post 18 months this thing, and now presented with graft dysfunction, post 13 months transplant, sir. Graft dysfunction secondary to the recurrence of native disease, or drug toxicity, reinfections. Yes.
So, the first component is that living related donor, ABO compatible, kidney transplant recipient. So, that is the first time of a diagnosis. In the native kidney disease, you would like to give one diagnosis or differential diagnosis? What is that?
So young female biopsy proven and she has a significant risk of treatment also.
But based on that alone, we cannot just have come to a firm conclusion about the diagnosis. We can always discuss the differential diagnosis. No? Because the injections are given for so many diseases and costly drugs are given for many diseases. Is it? So unless there is a telltale evidence for other evidence for SLE, it may be difficult to conclude just as SLE. She didn't have other phenomena of SLE.
No.
So, based on, of course, a young lady with any form of renal syndrome, we always have to think in terms of lupus, no doubt about it. But we cannot be categorical and pragmatic on this. Always come up with that. You just say it's a proteinuria was there, edema was there, so I think it strongly believe that it is glomerular disease. No, glomerular disease. In the order of priority, you just come up with the possibilities.
Glomerular disease, because of age and sex, I will first come with SLE diagnosis. SLE. Next can be because of age. She's at the time of diagnosis, she was 21 years. So it could be FSGS, MCD, or MPGN.
So MCD will it lead on to ESRD?
No, sir.
You should not say that.
Nephrotic syndrome at that age.
No, but it has there was a lingering damage and ultimately it culminated in ESRD.
Yes,
So never bring in MCD. So lupus can be IgA nephropathy.
Yes, sir.
IgA nephropathy, FSGS, C3G.
Or can be
So many. So it's anybody's guess, because particularly in a situation where there is no other evidence for lupus, right? Ultimately it was lupus, but we don't have. So better come up with a differential diagnosis.
Can SLE present with an isolated renal disease?
Yes, ma'am. Less than 5% it can.
Which group of patients? Young females or?
Male.
Isolated renal presentation in SLE? Elderly male with membranous class 5.
So you are telling this is SLE. This is not SLE. This is lupus nephritis. So you have to very SLE and lupus nephritis are two different things. Right? So tell us the proper terminology should be used so that they would be convinced that you are knowing and you have done presentation several times. So this was lupus nephritis. You have many other no differential diagnosis. So just tell me about the course of the disease. You have talked about how the lupus nephritis patients go into the ESRD. What is the duration of this glomerular disease illness?
So inherit is 5 years.
In 5 years, the patient progressed
to
to
ESRD because there was non-compliance and use of other medication.
not because of use of therapy, non-compliance, the patient reached to ESRD. So it is valid explanation. It is possible that those who will not take treatment can progress. So how many patients of SLE develops lupus nephritis?
So, yes, 40 to 60% they can have lupus nephritis. So during the course, 60% can develop lupus. At the time of presentation, 40 to 60% have lupus nephritis. So during the course, 60% can develop lupus nephritis.
At the presentation only 1/3, but subsequently during the course 80% of the patients might have lupus nephritis during the course of the SLE. Some patients may not have any time lupus nephritis. So you should understand this. So coming to your final diagnosis of this graft dysfunctions, you have told us this is looking like recurrence of the disease first. What was second?
Second could be rejections, chronic AVMR.
Chronic AVMR. Third subject?
Drug toxicity,
Which drug toxicity?
CNI toxicity.
CNI toxicity. Okay. So come one after other. Any other differential diagnosis?
The last I could like type 2 infections.
Infections. Right. We remember all 4 differential diagnoses. So you have to concentrate on this. So first you are telling this is a recurrence of the disease. So why you are thinking this is a recurrence?
So she presented the 13 months of post-transplant, sir, and her initial presentations like nephrotic syndrome on the background of unatypical kidney disease, glomerulonephritis.
So this was mainly the protonic presentation,
yes.
With normal graft function.
It's a normal graft function.
Normal graft function, and the patient you are thinking of the baseline has some glomerular disease, so this was a recurrence. Agree, fully agree. So what is the usual recurrence rate of the lupus nephritis?
Sir, it is less than 10%, sir, in post-transplant.
Post-transplant?
Less than 10%.
So this patient develops within 13 months, they came into the category of 10%. Some patients can have, 10% is also 10%, some patients might have. So in which category of the patients of the lupus nephritis very high chance of recurrence?
Disease activity at the time of transplantation, sir. She received a, like donor is also female living donor, sir, related to her.
So you are thinking that this donor has a SLE?
No, sir. Not the reason for that risk factor for
That's fine. So one is the activity of the disease at the time of transplantation, so that is fine. What else?
the APLA, presence of APLA, sir.
Yes, if a disease is active at the time of the transplant, many patients even on dialysis remains very active, lupus nephritis, and then you have to go for the transplantation because the patient is not doing well on dialysis. So what precautions you take?
We will continue immunosuppression during dialysis also, sir, minimal. So if there is serological immunity, no need for delaying of transplant, sir. Activity also. But some say because of dialysis there will be burnt out of the disease and the disease may become quiescent during dialysis period, sir.
So why disease becomes quiescent during dialysis?
SLE, sir. This one.
Why they become quiescent?
So there is no like viable global, there is no antigen.
The disease becomes quiescent, I agree with you, that is the right answer.
SLE is a systemic disease.
But that becomes quiescent during dialysis. You should know about all this. What is the immunological phenomenon happens during the dialysis? What changes happens amongst the different subgroups of T cells, Th1, Th2 cells, Th17s, how these modulate and why these patients on dialysis, what changeover happens, these patients go into remission, automatic quiescent.
Which glomerular disease is more likely to recur post-transplant? Rather, SLE is one of the diseases with the least recurrence because the UNOS data is the largest data available from spanning over 2 to 3 decades. An analysis of more than thousands of patients have SLE. The recurrence rate, if I remember right, is about 2.5% or something. So hardly ever we come across SLE recurrence. So if you discuss as a post-transplant glomerular disease recurrence, I would not entertain lupus nephritis as a possibility because there are certain other glomerular diseases which have a propensity to recur much more than lupus. Can you just mention in the order of priority, in the order of importance, the glomerular diseases which are likely to recur post-transplant?
Here I think she got biased because she was told that the biopsy is showing
That should not be taken into consideration for discussion.
Yeah. That's the reason.
First one is dense deposit disease. Second one is FSGS. Third one is IgA nephropathy. Fourth is membranous nephropathy.
So lupus nephritis as a, when you think of recurrence, because the treatment it depends on the most of these patients are on the same immunosuppressant which you like to use for lupus. So this was the recurrence. You have next you have told us this is a drug toxicity. Which drug toxicity?
So CNI and mTOR inhibitors can produce proteolysis.
Any points in favor of the CNI toxicity in this patient? As an nephrologist, as a transplant physician, you have to think of. So you cannot say these are the 4 causes, so every cause will fit into every patient.
So there is no relation with level of CNI, but attack levels remain like in desired range only, sir.
So any clinical clue that suggests you know this is looking like the CNI toxicity? When you think of this is a CNI toxicity, just reverse it.
What are the other manifestations of CNA toxicity?
Patient develops PTDM, hyperlipidemia, neurological symptoms, like cosmetic symptoms, alopecia, hypertrichosis.
So these are all the side effects of CNI. So you are knowing about the side effects of the CNI. So you are going on. You have to fit into the clinical scenario. You know everything, but you should know how to present this. If how common is the protrudia in patients of CNI toxicity? Happens or no happens?
Sir, because it just happens.
No, it does not happen. So if very unusual to have the protrudia. That is the one clinical clue in your patient. No, this is protrudic illness or significant protrudia. So it does not fit into this. Graft dysfunction can happen a little bit in CNI toxicity, can happen, but rise is usually not that happens in the rejections. So creeping rise in the serum creatinine, urine output remains preserved, and there would not be any protrudia. So that gives you little know. It is not looking like CNI toxicity, drug toxicity. So that is the one clinical clue. Third differential diagnosis. Over which rejection?
The ABMR,
Which kind of ABMR?
chronic ABMR.
This is not. So you have to, whenever you talk about the rejections, you have to tell me in total what kind of rejections you are talking about. So it is not that rejection. Rejection is very broad.
Chronic ABMR, antibody-mediated rejection.
Chronic,
Antibody.
active
ABMR.
or not active. Chronic, active, and
What are the
ABMR.
subcategories of ABMR as per the current banner?
Active, chronic, active, and chronic.
Huh?
Chronic, active, chronic, active, and chronic.
Is it? Chronic inactive. Active ABMR, chronic active ABMR, and chronic inactive ABMR.
आप
Isn't it?
guess करके भी बोल
And
सकते
C4D
हैं।
negative
Active
ABMR.
and inactive water.
These are the 4 categories.
So in which category you are trying to tell us? So what are the points in favor of the no? Probably it is looking like the chronic antibody-mediated rejection. What you are telling us. I am just giving you one point. It is looking more of the chronic active antibody-mediated rejection. That is the more common variety amongst all these, through which these patients after more than 1 year after the transplantations, they will come like this. acute antibody-mediated rejection. That is the finding in the early period of transplantation. So tell me, so what are these there in your patient that suggests, oh, this is looking like rejections?
So graft dysfunction is there, sir. No
Graft dysfunction, fine.
proteinuria.
So graft dysfunction of the CNI, or graft dysfunction in recurrence, or graft dysfunction in rejection. How these are different? Graft dysfunction is everywhere. Everything can be seen everywhere, but you have certain points that gives you hint. So only proteinuria, no graft dysfunction, recurrence. So when you have the creeping rise of the serum creatinine, no any change in urine output, right? And no proteinuria, CNI toxicity, drug toxicity. Here the patient has some degree of graft dysfunction, some degree of proteinuria, and urine output is preserved,
No, sir, decrease.
urine output decrease. So urine output in advanced stages of the recurrence also this can go down. But here again, this is all findings suggest of disease. What is more common cause of the any chronic allograft dysfunction? Rejection versus recurrence.
Rejection.
Rejection. So which kind of rejections are now coming back again to the chronic active antibody CABMR. We have no time too much to discuss about, but chronic active ABMR. Why this is so in your patients looking like?
And mother being the donor,
Mother being the donor,
immunologically no risk,
No.
low risk.
Yes, sir, low risk. The young age of recipient to old age of relatively older
There
age.
should be adherent to immunosuppressive
So
medication.
post transplant she is very adherent
We
to.
constantly take care, but because the pre-transplant behavior is one of the risk factors for, is an indicator for the post-transplant. Because pre-transplant she has been very irregular in treatment. So some studies have revealed that. Always we have to, you cannot simply believe what they say. We just conducted a study in our department, 28% prevalence of non-adherence to immunosuppressive medication, in spite of they getting the medicines free of cost.
45% in USA. Despite everything, so they are all well educated.
Yeah. And this DSA, if it belongs to IgG4, it will not present as acute antibody mediated. It will result in chronic pathology, creeping creatinine syndrome. That's what it is.
So this is the usual kind of thing. You have to put in the preferential diagnosis post transplantation so many years. Then it could happen. Everything you can fit into one diagnosis. It is possible that after doing the biopsy, everything can change. But for the clinicians, for the clinical discussions, you should have this variety. One very odd thing you have told us, infection. What kind of infection you are thinking of for the differential diagnosis? I am not asking you anything. What we have told, we are just sticking on that matter.
Post CMV collapsing FSGS can present with proteinuria.
Is it very common?
No, sir. Like,
Post CMV.
Very, very rare.
So any infection which can cause this kind of CMV, whenever you make a clinical diagnosis of the CMV infections might be seen in many patients. But usually such involvement you can see only when the patient has the CMV disease. And CMV disease is different from CMV infection. So CMV disease, was there any manifestations of the CMV disease in this case?
No, sir. No.
So set aside all these and try to find out the scenario, clinical scenario where it fits into. So infection, again only you can say some of the patient might have the PIGN happening in the graft. So then the scenario of the presentation would be different, might have the proteinuria, microscopic hematuria. PIGN can happen in a graft also. But so just see, you must have 2-3 points in your favor to put any differential diagnosis. It does not mean that All causes of the graft dysfunction you will keep in different cell diagnosis.
So one thing she already said is plasma exchange, sir, with IVIG.
Was that given for recurrence of lupus or was that given for rejection? In fact, I was going to raise that point that you could have used that as an argument in favor of ABMR.
The chronic KBMR plasma persist of not more like much
It
useful.
might be an acute ABG.
No, yeah, it might have been acute. We don't know about chronic.
More like post 1 year transplant also we won't use Plex as treatment for ABM.
See,
No, based on treatment, you cannot diagnose. Based on patient statement, you should not. Just keep that information by the side. That's all.
so in which category of the patient who will think of not to give any plasmapheresis, and in some category of the patient, even transplant patient, think of giving something. So what you will see, then you will try to treat. Then I will not try to treat if there is something very established in, if you are dealing with a chronic active antibody mediated rejection. अब जितने भी ट्रांसप्लांट फिजिशियन के पास भी जो सब कुछ थेरेपी दे देता है, you are telling, you are right that it does not cause too much of the difference in the final outcome, but practice is a little different. So what they see, they intended to give this plasmapheresis, IVIG or some
TMA, the post transplant. FSGS also we will do plasma persist.
this is the indication. You have just read out about the indication of plasmapheresis in post-transplantation. I was just enumerating. I am talking about in this patient's perspective. If
So there are no extra renal manifestations of SLE in these patients.
so chronic active antibody mediated rejections, what are the different findings? Based on that, any histological diagnosis will come out. This is chronic active antibody mediated rejections. Tell me the histological finding. 1, 2, 3, 4.
The chronic active ABM are also category 1 and category 2 are same, sir. That is microvascular
Histological
inflammation.
findings. Tell me histological findings. Based on this, pathologist gives you this is a CAPMR.
Microvascular injury in the form of glomerulitis and peritubular capillary, sir.
Fine,
Acute
great.
tubular injury.
Yeah.
Like intimal arteritis, sir. And evidence of C4D positivity, sir. And raising gene transcripts.
And what they see, then they said chronic.
TMS, PTC.
The chronicity, how they say this chronic. आपने बोल दिया active antibody
Active
mediated.
ABMR. When will you say this is chronic active ABMR?
Duplication and thickening of the basement membrane. PTC multi-layering.
Multi-layering capillary basement membrane thickening and duplication, that suggests you probably we are dealing with a chronic active antibody mediated rejection, and everything settles down. Right? So happy degree of recruitment. So then transplant glomerulopathy. Transplant glomerulopathy, CAPMR is one of the common associates of this transplant glomerulopathy. There, whatever you will do, there is not too much of disease. If some disease activity is going on, then people tend to give some plasmapheresis not to achieve this full target, but they try to give. So, what else you will do, and then we can decide. In you have many newer investigations in your armamentarium. So anything which will help you in guiding this.
Cell-free DNA, sir. Or dsDNA.
Cell-free DNA is again the new things, but fine, but it does not help out in making treatment in this in chronic. That is for the all acute. So more important, more commonly practiced.
Creatinine.
Donor specific antibody, single antigen BDSA you can go for, and which category of antibody you will see, and then decide.
Class 2 antibodies will be more common in chronic.
They are very refractory to get this desensitized or get it removed, and you will do, it will reappear. But if some has the donor specific antibody of the class 1 and class 2, that also can be, even if it is in lower titers, they are liable to be desensitized. But DQ is very difficult to desensitize. So then you can think of sometimes giving that is might be the individual practice at different centers, but you should have an idea of what all these things, what kind of activity, what we will do. We will get the SAP. For when you are categorizing these rejections, you have a physical antigen beta say available everywhere now. So we should categorize like that. So how will you manage this disease?
Sir, actually, she received plasma exchange analytics by also, sir. We have to we can see for if it is rejection till 3 months.
So biopsy you will do? Biopsy
Already done, sir.
What is the biopsy finding? Do you know? What is the biopsy?
The recurrence of lupus.
Which recurrence? Which choroid disease?
Class 4.
Lupus recurrence?
Lupus.
Lupus class 4.
No, even if you know the diagnosis, you pretend as if you don't know. Because if you say lupus nephritis, I'll be thoroughly disenchanted. DM nephrology exam is not about telling the right diagnosis, it is the right approach. There are always surprises. But why I am saying that is, the SLE lupus nephritis recurrence is very, very rare. Probably she is off drugs.
All
There's
drugs
a non-adherence.
or
Otherwise,
mismanaged.
if you are on MMF, tacrolimus and prednisolone, recurrence of lupus nephritis is very, very rare. Even that UNOS 2.4% recurrence dating back from 80s, where a substantial number of them were on azathioprine. With MMF tacro regimen, lupus nephritis recurrence, probably she's a defaulter. That is the. Any newer therapies for chronic ABM or anything? Lasicizumab. What is that? IL-6.
Now there are a combination of IL-6 and IL-17. That